Hello and welcome to the GRACE podcast series. My name is Denise Brock and I'm the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast, members of the GRACE Board of Directors, Dr. Jack West, Dr. Jared Weiss, and Dr. Ben Levy all sat down in their respective homes to have a candid discussion regarding COVID-19 and how it affects primarily cancer patients. In this 4-part series, the doctors discuss testing, risk, preventive measures, ongoing cancer treatment, and many other issues relating to a cancer diagnosis in the middle of the pandemic. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
One issue that I think many patients may be concerned about is that we are increasingly looking at the schedules and protocols for our treatment, our patients' treatments, and saying, I think you can go a longer interval before coming in for treatment. We could go 4 weeks or even 6 weeks between immunotherapies. We can go an extra month before your next scan and labs. And I think many patients are fearful that they're being pushed aside or not optimally treated. And I would ask if you guys can comment on this. My sense that I would like to convey is that the risk of coronavirus infection and COVID-19 changes the equation and introduces a different level of risk that wasn't there before. And because of that, we need to adjust accordingly. And many of our treatment approaches that were based on every 3-week visits or 3-month scans are really relatively arbitrary. And when we pull back and ask, is it likely that patients wouldn't do as well if we went to 4 weeks or went a longer interval between scans, or even a televisit instead of a live visit, that this is not minimizing their disease or under-treating it to the best of our knowledge, but trying to accommodate a new risk that wasn't there before. And I'm just interested in your thoughts on how you would explain this and really hope to provide reassurance to patients that people with metastatic lung cancer are not going to go untreated in this environment.
You know, Jack, we're already used to, in the doctor-patient encounter, having more knowledge than our patient, right? You've treated however many hundreds of thousands probably of cancer patients and have a lifetime of experience in doing this. For them, this is their first time or one of their first times in that scenario. So it's always been our job to understand the relative risks of choice A versus choice B versus no action, and to engage in shared decision-making with an educational component to our patients. One word you used that resonated very strongly for me was the word equation. This is sort of human math, right? The risk of treatment versus non-treatment, the risk of scanning on a standard interval versus at a longer interval. Is the risk greater of the cancer or of the exposure from COVID-19? And I've seen both reactions from patients. I've seen the fear of their cancer being pushed aside. I've also have seen situations where curable patients are not willing to come in because they're so deathly afraid of COVID-19, where the cancer risk actually vastly exceeds the SARS coronavirus 2 risk. And so I think that's incumbent upon us to partner with our patients and to do that human math and to have a conversation translating that into plain English to help with that. And I do think it's different by the kind of treatment we're giving. I think immunotherapy, for example, is very forgiving of an increased treatment interval when there's a practical reason to do so. I think with targeted therapy, it's pretty rare that finding out about progression a little bit early actually helps the patient in the long run. I think increasing the scan interval is a little more forgiving. On the other hand, for a patient on cytotoxic therapy, where the patient is accepting a significant risk of side effects in exchange for the hope of longer life and better quality of life vis-a-vis preventing progressive disease, I think there it's critical to have a granular understanding of whether you're actually helping.
Ben, your thoughts?
I think that was stated well. I think that, one of the things I like out of that commentary is just the shared decision-making based not only on education, but based on our best guess, our intuition, and medicine as an art and not a science. And, I think we have to have these conversations with our patients. I think we want to limit the risk of exposure to this virus, but at the same time, still deliver a regimen at an interval that we think is therapeutic, that minimizes toxicity and exposure. And this is not data driven. We have no data, or very little data at this point, on what this does to outcomes. And I think that, as Jared said, I think that, with targeted therapies, it's a little easier. I think with cytotoxic or immunotherapy and infusion-based treatments, it's really a shared decision-making process with the patient, where we have to talk about the benefits versus the risks. And yes, we are pushing out these intervals. And yes, I'm telling patients that, we think that this helps mitigate the risk, and at the same time still delivers an effective dose that can achieve the same outcome as if we were doing it at the regular interval.
And I think one key point is that because of this, less may be more.
Yeah.
We have, for instance, not just talking about changing the intervals, but if we're treating patients ongoing with immunotherapy, and that may go on for a year or two, and we don't even know if we might want to or need to stop at 2 years or keep going. Sometimes we've kept going just because we don't know when to stop, but we may well be at or past the point of diminishing returns after a year. And it may be very sensible in this environment to pull back and really stop that maintenance therapy that may add no benefit, but may give an increased risk, particularly if you're in an area where exposure is very realistic concern. So sometimes even stopping treatment may be an appropriate consideration that may be a very good strategy, and not just dismissing the patient. Last question I wanted to ask is, people are hearing about hydroxychloroquine, perhaps with azithromycin, or all sorts of other things. There's convalescent serum. There's many ideas out there. We are not infectious disease specialists, but what can we say about treatments for COVID-19 at this point?
Pay attention to the presidential briefing.
No.
So
you said it,
I
not
think
me.
Website manner, I'm more casual than most, but I think the key thing to tell our patients is to do nothing preventatively. These are unproven regimens, particularly hydroxychloroquine with or without azithromycin. I'm very skeptical about whether that's going to ever end up being positive. I'd love to be wrong. We all want effective drugs, but what I think is not controversial is that it has not been proven at this time. And these drugs have very, very real risks of harm. We've started to see that in practice, people who've never needed them having significant harms. And so that this is not something to be done willy-nilly. This is, if one of these drugs is considered, to be doing it together with someone who knows what they're talking about, particularly in the absence of hard data.
And again, we're talking about outside of a clinical trial. There are various clinical trials being done. And we're also talking in mid-April of 2020, and we may know different things I hope we do, in May or June, but we are all learning as we go. And I think the strongest point that we can make is that we absolutely don't know of a clear, effective standard therapy, and anybody who is a strong proponent of one is making it up or doesn't understand how to judge clinical data at this time. So I think that we would not.
Jack, you're tempting me on the political jokes. You're tempting.
But I think the reality is that we don't want patients demanding something based on misinformation.
That might hurt them. That's more likely to hurt them, than anything, particularly in the absence of a severe COVID-19 syndrome.
And Ben, what are your thoughts here? What are is there anything that you have a lot of hope or promise about?
I think it's just a call for clinical trials. That's what I'll end. I think it's a call to streamline the process, to open up the doors that this can be done, efficiently and effectively, in a meaningful way, in an iterative way, in a scientific way. We don't have answers yet. They take some time. But we're not there yet. But this is a call to kind of open up the doors and get these trials rolling, which they are. So kudos to the FDA and others and the institutions that are running these trials to try to evaluate some therapies that are rooted in some scientific rationale.
Great. Well,
and I would point out one that wasn't mentioned of particular importance, I think, in the long run is vaccination. Once that to me is going to be one of the cornerstones of rolling this back and getting back to normal life is an effective vaccine. The 3 in trials right now are unfortunately whole virus essentially, which in plainer English is a kind of 100-year-old approach, but you see some novel and more savvy approaches making their way towards phase 1. And you asked Jack about what an opinion on what has the most hope. That's where I'm most excited.
But it's also important to add the caution, the caveat that this is not something that's going to translate to a transformative strategy in June. This is something that is going to take, at least 12 or 18 months, potentially longer. I mean, I would love for it to be better, but I think it's not going to be weeks or a few months. I hope that it gets expedited. Obviously, the whole world is focused on this, and it would be transformative to restore life in any semblance of how we knew it before. I would like to thank my colleagues, Dr. Jared Weiss and Dr. Ben Levy, for taking the time and to say that we obviously haven't answered every issue or question. This is ongoing, and there's going to be a lot more to talk about. We might hope to reconvene at some point in the future to cover things as they continue to evolve. I hope you'll be interested and find this series hopeful and helpful, and we'll look forward to talking to you again. Thank you, guys.
Thank you again for joining us. This podcast was made possible by the generosity of sponsorship from our friends at Lilly, Novartis, Takeda, AstraZeneca, and Exelixis. Please like and follow us on Facebook and Twitter. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.